Hey, what's happening, guys? Welcome back to Tea Time with Trivedi. Today we're going to talk about Parkinson's disease, and with me I have two students from UIT who've done their research for one of their courses. So they're going to be sharing their research findings. And Parkinson's for me is also a very personal disease that I've seen family members go through it. So, I know quite a few things. You guys know quite a few things. So let's have a discussion and let's inform our listeners. What do you guys think?
Sounds good.
Okay, guys, grab your teas because you're in for an informational session.
Well, with that being said, let me introduce our first guest, Manan Patel. Manan will tell us more about Parkinson's disease. So, Manan, take the mic.
Sure. So, Parkinson's is a progressive neurodegenerative disease. It's called a progressive disease because as time goes on, the disease gets worse. The term neurodegenerative means a loss of neurons in the brain. In Parkinson's disease, the dopaminergic neurons, these neurons produce an essential brain chemical known as dopamine. But when the neurons die or become impaired, there is a shortage of dopamine. Now, dopamine, as you may know, is responsible for normal movement. With a reduction of dopamine, tremor, stiffness, and slow movement occurs. In addition to these three main symptoms, sometimes patients also suffer from balance problems. Unfortunately, there is no cure for Parkinson's. However, there are treatments to improve symptoms.
Thank you, Manan, for that. So, as we said, PD is a chronic disease, and I think what the most challenging part about PD is the fact that there is no cure for it. I've seen patients get severely affected by this disease, and the effects went beyond the pathophysiological manifestations of the disease. Having PD means it affects the patient's quality of life by physically inhibiting their daily activities. It also takes a toll on their mental and social life as well. I have a stat here which says 43% of Canadians who are diagnosed with PD feel embarrassed, and this is Stats Canada 2015. These things are very important when dealing with Parkinson's patients, and it's essential that they're not overlooked. We know that PD progresses over time from mild to severe forms. I would like to note that oftentimes mild symptoms are overlooked and are not detected until they're amplified later on. And as we move towards the spectrum of the severe end, all motor and cognitive defects, I just find it so fascinating how fast they tend to deteriorate. Those were the characteristics for Parkinson's disease. So the primary symptoms that come along with Parkinson's disease include bradykinesia, which is the slowed initiation of voluntary movements, muscular rigidity, resting tremor, and postural and gait impairment. So essentially, you have a hard time starting movements, you tend to freeze, you tend to shake, and you have a hard time keeping your posture up. Other symptoms include characteristics such as stooped posture, the slow shuffling gait, you walk without swinging your arms. At times, there's a lack of facial expressions. And then there's also non-motor features of Parkinson's, which is olfactory dysfunction. That means you can't smell properly. You have psychotic symptoms, you have sleep disorders, and autonomic dysfunction as well. Sometimes some patients experience pain, some experience depression. But I would also like to add that all these symptoms vary from person to person. Myth, would you want to tell our listeners how Parkinson's is diagnosed?
Yeah, it's absolutely hard. So, as for diagnosis, it is very difficult to diagnose Parkinson's disease early on, but we do follow some diagnostic techniques that help us do this. And one of the most popular ones is MRI and transcranial sonography. What this does is it helps us detect structural changes, such as neuron loss in the brain. Another thing that we use, quite popular as well, is SPECT scan. What this is, it's a type of nuclear imaging test, which means it uses a radioactive substance and a special camera to create 3D pictures. Another technique again is presynaptic dopamine terminal function, or functional imaging for atypical Parkinsonism. As for the clinical tests, what it does, it helps us with staging and the degree of progression. Now, Hart, I do know that you also have some information up on this, and you did do your research on this as well. Would you like to talk about that?
Oh, yes, of course. It is a very complicated process, but without going into too much details, it essentially is a new area of research that is trying to utilize eye movements and trying to draw associations with neuro-oculomotor deficits. And essentially, a person without PD would have normal saccadic and anti-saccadic eye movements, while a person with PD would have an abnormal presentation. These oculomotor tests can be great predictive tools in early diagnosis for PD. It also allows us to determine if there is any accumulation of early biomarkers that could point into a pathophysiological state. We can figure that early on. These eye movements can essentially help us determine how far along a person is in the process. So moving on from eye movements, Manan, would you be interested in telling our listeners more about the risk factors for Parkinson's disease?
So the causes are actually unknown, but there are actually several contributing factors, such as dietary consumptions. So like dairy products, alcohol, and increased saturated fats. There's also biological risk factors such as HPV, cancer, brain trauma, and reproductive factors. You can also change the modifiable factors by blood cholesterol levels, hypertension, and high BMI.
So essentially, if you are active and you work out, you can take yourself out of risk.
Yeah, for sure. By exercising daily, doing regular physical activity, you can lower your chances significantly. There are also non-modifiable factors such as predisposition to age, sex, race, and genetics. There's also risk factors that are associated with chemical exposures, such as pesticides and meth.
Wow, that was a long list of risk factors for Parkinson's disease. I also noticed that you mentioned genetics. That's something I actually looked into. With Parkinson's and genetics, there seems to be some association. A lot of studies that we found when I was doing my research was that several genes have been discovered that show high association with Parkinsonism. And one of them is SNCA, which is synuclein, PARC2, PARC7, which is basically Parkinson's disease autosomal recessive juvenile 2 and early onset 7, PINK1, which is P10 induced putative kinase 1, and LRRK2, which is the leucine rich repeat kinase 2. Just so our listeners don't get tired of hearing our voices, I asked someone to call in. She is not in the country right now, but she's very happy to contribute to this discussion on Parkinson's. Her name is Ruchita. I'm pretty sure you guys know her from UIT. She takes great interest in epidemiology, and she'll talk to us more about epidemiological factors. Hey Ruchita!
Hey Hard, I hope you're doing well. So let me tell you a little bit about the epidemiology of Parkinson's disease. Epidemiology includes factors such as prevalence and incident rates. So prevalence rates is used to quantify the total number of current individuals diagnosed with Parkinson's disease in a population at a given time. An estimated prevalence rate of Parkinson's disease in industrialized countries is 0.3%, 1% in individuals above the age of 60 years, and 3% in those 80 years or older. It is commonly diagnosed in individuals above the age of 60 with a prevalence rate of 4.5 to 21 cases per 100,000 population per year worldwide. On the other hand, incident rates are estimated based on the number of subjects diagnosed with Parkinson's disease in a given time for a population at risk. As per a prospective population study conducted in 2016 by the New York University School of Medicine Department of Neurology, 8 to 18 per 100,000 person year individuals were diagnosed with Parkinson's disease yearly. Another aspect of epidemiology is mortality and survival. So mortality for patients with Parkinson's disease decreased from 4.9% in 2002 to 3.3% in 2011. Parkinson's Disease Foundation states that people with Parkinson's disease have a higher risk of death than the general population. Gender and race play a significant role in predicting the survival of an individual with Parkinson's disease. Women have a 26% lower risk of death compared to men. African Americans have a higher crude death rate, up to 66%, followed by whites, which is 65%, Hispanics, which is 55.4%, and Asians up to 51%. And 70% of patients diagnosed with Parkinson's disease develop dementia. Those diagnosed with dementia have a higher death rate, which up to 72%, compared to those without dementia, which is 46%. With recent technological and clinical advancements, life expectancy of patients with Parkinson's disease has increased. However, the lifespan is less than that of the general population. Another aspect of epidemiology is age and gender difference. Both prevalence rate and incident rates vary greatly across age and gender groups. Males above the age of 60 years are more likely to develop Parkinson's disease compared to women. Incident and prevalence rates are 1.5 to 2 times higher in males than females. Women present a milder phenotype than men. Non-motor symptoms that are more prevalent in women are anxiety, depression, and constipation, whereas men suffer from daytime sleepiness, drooling, and other symptoms.
Whoa, it seemed like Ruchita had a lot of facts about Parkinson's and epidemiology. Myth, I'm going to pass the mic on over to you. Why don't you explain the criteria that Parkinson has to meet to be classified as a chronic disease, and then why don't you define why it would be a complex chronic disease for our listeners?
Yeah, thank you, Hard. So let me just talk about the chronic nature of Parkinson's disease. And according to the Ministry of Health and Long-Term Care, chronic disease are long-term diseases that develop slowly over time. They often progress in severity, and just like Parkinson's disease, they can be controlled but not cured. So the chronic nature of this can significantly impair everyday physical and mental functions, and this can also reduce one's ability to perform activities of daily living. So in patients with Parkinson's disease, symptoms develop gradually and may start with ever so slight tremors in one hand and continue to worsen over time. So like I said before, there is no cure for Parkinson's disease, and treatment options such as medication and surgery management, it just manages its symptoms. Like I said, again, there is no cure. As for the everyday physical and mental functions, they are impaired depending on the severity of the disease itself. So as the disease progresses, the impairment also gets worse, and the patient's ability to perform daily activities is reduced over time.
Thank you for telling our listeners why PD is considered a chronic disease. Why would it be considered a complex chronic disease?
So there are actually several aspects of how Parkinson's disease can be complex. The first factor is to consider if there is a comorbidity or multimorbidity with Parkinson's disease. The prevalence of more than one disease often increases the risk of Parkinson's itself. In fact, a 10 or more year prevalence of type 2 diabetes was associated with 41% increased risk of Parkinson's disease. And people with chronic obstructive pulmonary disease, or COPD in short, were 37% greater at risk of Parkinson's than those without COPD. Another aspect of how the disease itself can be complex is healthcare utilization. It plays actually a significant role, and increased resources allocation to a specific area of health. So a study published in 2012 looked at the average number of days a person with Parkinson's disease needs hospitalization versus a person without Parkinson's disease. And what we found was the average number of days a year a person with Parkinson's disease spends in hospitals related to other mental disorders is 22.7 days. So in comparison, a person without Parkinson's disease spends only 14.2 days related to other mental disorders. To add on to this, it is shocking to see that an average person with no disorder at all spend only 1.1 days in average at the hospital. Those are everyday people that you see on the streets that you don't think that, they don't have Parkinson's. They're just your colleagues. They spend maybe 1.1 days. And again, when you're comparing it with somebody with Parkinson's, they spend 2.9 days in comparison. So this can also cause comorbidity, and this altogether makes it complex.
Now that we have talked about everything important related to PD, I think this is the most exciting part: rehabilitation methods. There are so many ways in which symptoms of PD can be managed and the quality of life can be improved for the patients, and all of these avenues I think are very exciting. I'll leave it up to our guests to talk about an area of their interest in non-invasive methods, and I will talk about invasive methods that help PD patients. So Manan, why don't you take the lead on dance therapy?
An interesting form of therapy that popped up when conducting this research was Argentine tango. EHART in 2009 highlighted 4 key areas that were recommended for an exercise program to focus on, which were cueing strategies to improve gait, cognitive movement strategies to improve transfers, exercises to improve balance and training of joint mobility, and muscle power to improve physical capacity. McKenna and colleagues were the first to report the benefits of Argentine tango for frail elderly individuals who did not have Parkinson's. They compared 2 groups in which one group walked for exercise and the other danced the Argentine tango. Individuals that performed the Argentine tango demonstrated greater improvements in both balance, walking speed, and improved strength in both groups. However, early intervention would be beneficial to improving and preserving the function of those individuals that have Parkinson. Another important aspect of the dance may be the specific movements incorporated in the program. There is evidence that supports task-specific training in order to strengthen the particular task. An individual should be constantly practicing the similar task repeatedly. Similarly, in a study conducted in 2015, Therapeutic Argentine Tango Dancing for People with Mild Parkinson's Disease, a feasibility study by Blandi et al., showed the therapeutic dance to be enjoyable, thought to improve mobility, balance, and well-being in some people with Parkinson's. 6 individuals were recruited that had mild to moderate Parkinson's from support groups, movement disorder clinics, and Parkinson's associations in Australia. The individuals participated in 1-hour dance routine, performing the Argentine tango twice a week for 4 weeks. The primary outcome was feasibility, which was determined by measures of recruitment, adherence, safety, and resource requirements. The results that were seen after 4 weeks of completion of the dance studio was the method was safe with no adverse effects. There was also an 89% adherence to the dance program, and after full completion of the dance, the depression scores were improved. Overall, the Argentine Tango dancing program was shown to be feasible, safe for people with mild to moderate Parkinson's, but however, more research needs to be done to support further dance therapeutic interventions.
Oh man, that was a really interesting take on rehab methods. Who would have thought that dancing could have such an impact on patients? Um, Speaking of unorthodox rehab methods, I think Mit, you would like to share the aquatic therapy study that was done and how that impacted patients' lives. So dancing and swimming could be our next rehab method to help patients overcome their Parkinson's symptoms. So I'll pass the mic on to you, Mit.
Yeah, absolutely hard. So actually in 2011, doctors Vivas, Arias, and Cudeiro conducted a study assessing and comparing land and water-based therapy for patients diagnosed with Parkinson's disease. The study took place in Spain, and 12 individuals were randomly allocated to the land-based therapy, which is the active control group, or the water-based therapy, which is the experimental group. So a physiotherapist made each individual perform specific exercises for 4 weeks, twice a week, for 45 minutes. The only difference being performance in water or performance on land. Results were evaluated based on 5 variables: functional reach distance, BBS score, gait, tug, and UPDRS score. After analysis through t-tests and p-values, results show water-based therapy seems to be more effective than land-based therapy when it comes to function and movement.
Thank you guys for sharing your information on non-invasive rehab methods. I really agree that these methods help improve the quality of life for patients. I personally looked into deep brain stimulation, and I think it's the best way to deal with Parkinson's. The evidence also suggests that for our listeners, deep brain stimulation, or DBS, is a surgical procedure which is used to treat symptoms of Parkinson's and other disabling neurological conditions. It's essentially delivering an electrical stimulation to specific regions in the brain that control movement. And by doing so, we can block the abnormal signals that cause symptoms. This procedure does not damage healthy tissue, rather just blocks electrical signals from certain parts of the brain. For example, the subthalamic nucleus and a portion of the globus pallidus, which is the globus pallidus inertia. So the 2 studies I examined was, one of them was an RCT and the other one was a meta-analysis of RCTs, which showed effectiveness of DBS as well. To disseminate the findings amongst us, the first RCT was a 36-month outcome study, which examined the comparison of DBS between 2 regions of the brain, the subthalamic nucleus and the globus pallidus inertia, and how it affects motor function and quality of life. It showed great external and internal validity both. I used the Pager scale to determine this. Compared to the baselines that were taken for the both blindly allocated groups, the results showed improvements in motor functions, which over a period of time, and after that it was followed by stagnancy. The quality of life and the neurocognitive functions also showed a declining trend, and that's understandable because of the way Parkinson is. The effectiveness of DBS, in my opinion, is still the most evidence-based practice that's out there, and it remains consistent with studies shown all across the academic community. And I think based on what I've read, it shows from anywhere between 25 to 60% improvement from the studies that I've seen. The second study was a meta-analysis which examined over 500 RCTs and narrowing it down to 7 samples. And these 7 samples were examined by 2 researchers, and it was done independently to eliminate any kind of bias that might be there. The aim was to determine how the DBS affects cognitive domains. And the study was very well done based on a scale that we borrowed from the National Institute of Health, which is kind of like the Pager scale for meta-analysis. It met 7 out of the 8 criteria that were there. Again, the results of this study, it showed that DBS improved the quality of life and helped manage PD symptoms. I guess what it comes down to at the end of the day is our patient, the quality of life the patient has and how we can help them manage the symptoms of PD. Well, I guess that sums it up. Thank you guys for showing up. I had a really good time chatting with you. Ruchita, if you're watching, thank you so much for phoning in. And to our listeners, stay tuned for next week's episode on concussion. Till then, I hope you guys have a good time. Keep drinking your tea. Keep reading. Take care. Have a good day.